complicadas, especialmente temas o ideas de ciencias o medicina o la salud pública muy, muy importante. Y por eso voy a hablar en mi lengua primera. Y lo siento. So, and thank you for the translators for making my words understandable for those of you who don't speak English. But I will speak English for the rest of my talk, and this is also part of my usual. So for the past 5 years, I have been very privileged to work at GEVIHS Healthcare as one of the global medical directors. And our role is to be ambassadors of the company, ambassadors for her medicines, her research, her public health initiatives. And I've been very proud to help represent those efforts that I think have changed the way we think about treating HIV, have changed the way that we think about preventing HIV, and have advanced important ideas around health equity, ideas around improving the voice of comunidades, of people living with HIV, and to serve as the ambassador of communities of people living with HIV, communities affected by HIV, and for their doctors and nurses and pharmacists around the world. And for that last reason, it's especially important and profound for me to be here today, to return to Merida. So my talk today is one of 2 lectures I will give today. And this talk is aimed to give you an overview, but less detail, because this is a very broad subject. And to give the overview will not provide the time for the details, but I'm happy to discuss this later, perhaps over a nice meal. So, and it's also aimed, yeah, que sí, ¿no? Especialmente con la comida yucateca, ¿no? So the objective here, though, is also less about cultivating debate about very fine details of science, and more to convey a survey of where the current science is for medical providers, for clinicians, many of whom are early or middle of their careers. So what can we take from the science? How can we apply this to the clinic? And so this morning, I will talk about metabolism and HIV, and metabolism and antiretroviral therapy. Okay, ¿está bien? Okay. No? Okay. As you know, this is my disclosure. I am now a full-time employee of a private sector drug company, GEVIHS Healthcare. So to start this conversation, metabolic health, of course, has been a subject that has been of great interest to all doctors, except maybe gynecologists. That's a joke. No, so metabolic health is very broadly important, but because of the advances in HIV medicines, what was once seen to be not important for people dying of AIDS is now important because people living with HIV have life expectancy, which is essentially normal. Okay. So this is a relatively new area of importance for people in HIV medicine, right? Maybe only 10 or 15 years have we really focused on metabolic health. And it's because of the successes in antiretroviral therapy. I don't have a watch to look at my clock. Okay. So metabolic health has many definitions, and for purposes of this discussion, I will limit the discussion to these topics. So we'll talk about weight, lipids, glucose, and insulin resistance, and again, also talk about this somewhat vaguely defined thing called metabolic syndrome. when we think about this in general health, general medicine, we know that there are many things that can affect metabolic health, right? Many things that are unrelated to a virus or medicines. They include, of course, diet, food, importantly, food insecurity, which I think very recently has now been coupled to interesting biological and physiological science. So food insecurity actually affects metabolism, as does the trauma of housing insecurity also causes metabolic consequences. We know that there are genetic or host factors such as race and ethnicity, sex, family history, other comorbid diseases, of course. Many of us in the clinic struggle to get patients to really implement changes in activity, but the amount of physical activity, opportunities for physical activity, that means where you live, what kind of job and such, the safety and ability to walk in one's home or neighborhood also affects metabolic health. We know that habits, behavioral habits, smoking, alcohol, recreational drugs affect metabolic health. And of course, a big component that is often not controlled in many clinical trials is mental health, depression, stress. A very interesting topic that is emerging in the last several years is the effect of stigma and discrimination on metabolic health, on inflammation. Right? They're done. Really interesting work. And as we all know, as HIV doctors, stigma discrimination affects all of our patients. And so now imagine that this has inflammatory and metabolic consequences. And I'll leave that topic with the proposal to all of you that this is a subject to follow closely. When we find things that we can't explain in inflammation and other metabolic parameters, is this related to food insecurity, housing insecurity, stigma, or discrimination? Quite interesting. But as we think about HIV more specifically, then we go into more conventional buckets, themes, or columns on a PowerPoint slide. We think about things that are related to the virus or our immune response to the virus. So inflammation, microbial translocation in the gut, fat, body composition and fat changes also affect metabolic health. And lastly, although this is often where people who work in drug companies start this conversation, is the effects of specific antiretroviral therapies or other medicines. So the notion of metabolic health is a very complicated one with many variables that can impact health, where some, I would argue most, are probably not related to HIV or medicines, but as HIV doctors, we will focus on those as well. So let me break this down then into a relatively rapid overview of each of those subtopics. What I'll do is give an overview of the general health aspects, and then a more specific overview of the HIV-related factors, very lightly brushing on the most recent data and science presented at recent large conferences, specifically the International Congress in Montreal last summer and CROI in the early part of this year, okay? What you'll see from all of this is that there's tremendous interest. There's a field that is well established from general medicine, and there are observations from the HIV-specific areas, but there's a lot of heterogeneity, or that's to say controversy, about the specifics of the HIV contributions, okay? So this is a statement about the general health of weight in the population. These are international data that says that there's a global problem with being overweight and obese. And this is around the world. And of course, in the Americas, the problem of obesity is actually the greatest in the world, mostly related to people in my country. Now, in terms of the effect of HIV in populations on weight and weight trajectories is shown by this very large study conducted in the United States, looking at now not just the weight at any given time, which is often what we see in clinical trials, but it's actually the trajectory of weight change over years. And what you see is that everybody gains weight as we get older. And it's a battle that those of us who are older struggle with more than when we were younger, self-included. And the interesting observation here, though, is that if you look at the slope of these lines, and this is, again, data now that was disaggregated based on baseline weight, you'll see that everybody gains weight. The slope, it goes up from left to right. But the steepness, the slope of the lines for those people with HIV in red is steeper than those for people who, in the general population, or people who do not have HIV. So there's something different about having HIV and receiving its medicines that makes that trajectory of weight gain different over time. And this is over a 10-year or more horizon. So there's something there, but what is it? So we know that HIV itself, untreated, leads to weight loss, but HIV medicines, of course, restore health and restore the potential to gain weight. But we also know from other studies, and these are data from a pooled analysis from 8 large Gilead clinical trials in therapy-naive individuals, and shows that there are specific medication effects. And so this will be a theme that kind of comes through repeatedly in multiple studies, and this is one of the larger studies to make this point, that the second-generation integrase inhibitors, dolutegravir and bictegravir, were associated with more weight gain compared to boosted medications and non-nucleosides, and this seems to be reiterated through multiple studies. And tenofovir alafenamide, TAF, was associated with more weight gain than other nucleosides. So the hypothesis, the simple hypothesis, was that these medicines cause weight gain, but I think it's important to recognize that it's also entirely possible that the other medications blunt the ability to gain weight. So it's not just a single cause or effect, it could be actually a mixture of these things. The other thing I want to point out on this data set was that this was with people who are therapy naive. And the trajectory for weight gain when therapy naive is, of course, a restoration of health as well as the typical age-related weight gain. This is a study from South Africa that really brought this to everyone's attention. It's called ADVANCE. This was, again, a study conducted entirely in Southern Africa, and points out, again, the observation that people in this study who were on dolutegravir gained more weight than people who received efavirenz, and that people who received TAF gained more weight than those people who received TDF, tenofovir disoproxil fumarate. Okay? And again, these data now have been replicated in various ways, although again, the specifics have that heterogeneity that are probably due to the other factors that we talked about. So this is a summary of the more recent data, and you can see this is broken down by treatment category: naive people, people who were switched to an integrase inhibitor or switched off of an integrase inhibitor. I won't go through them in detail because this is one lecture in this one slide. Okay? But to show you that what I showed you the primary data for has been replicated in multiple other studies around the world, although the effect size is different in different studies and different populations of people. These studies also point out that sex at birth seems to also be a factor here. So women tend to gain more weight than men. And the other interesting observation is that when removing the INSTI, the integrase inhibitor does not seem to result in return of weight. Okay. So just to quickly summarize then, these studies over the past several years affirm the idea that in addition to the integrase inhibitors and TAF, that female sex, non-white race, age, baseline factors seem to affect weight trajectory. It's also important to know, and this is a demonstration of the fact that important other medical things, in this case, COVID pandemic, also affects weight trajectory. And again, it points out that the observation in one clinical trial can be confounded by many, many other things that are very difficult to control in a clinical trial, okay? And I'll just leave it at that because that's really the important conclusion. And of course, weight gain is a massively important part of the research agenda. This is a summary of most of the clinical trials that were presented at CROI in Seattle. You can see there's a lot, but I think the quick takeaway is look at the direction of the arrows here. Some studies showed not much long-term effect. Other studies showed increase of weight in men or women more than men. And some studies showed loss of weight depending on the intervention. And so again, there are many factors that seem to generate this. This is getting to my hypothesis that the data is quite heterogeneous and the results from one clinical trial might not represent the full truth of the story as it pertains to a specific population or a specific medication intervention. I think I just summarized brief, and this is, again, the quick summary of it. We can go through this in detail after the talk, okay? All right, let me move forward for sake of time. Let's talk about metabolic syndrome. So what is metabolic syndrome? Again, the endocrinologists have a very specific definition of this, but even there's some variability, and there's some differences and arguments about what this is with internal medicine doctors and so on. But overall, it's an association or a condition associated with abnormal carbohydrate and lipid metabolism. It seems to be associated with 4 risk factors: insulin resistance, hypertension, obesity, and dyslipidemia. Most clinicians spend a lot of time thinking about hypertension and dyslipidemia. We see obesity, but we really don't spend a lot of time quantitating it in the clinic. Measure a weight, maybe do a BMI, and that's the end of the story, but we actually don't think of obesity as a contributor to these other things. Okay? But why is it, so regardless of the definition and regardless of how you manage it in the clinic, it's important because it increases the risk of disease outcomes that are bad: type 2 diabetes, cardiovascular disease, coronary artery disease, and stroke. Okay? So regardless of how you get to those things, we all can agree that those end organ diseases, in fact, are very serious. And here's a quick takeaway. The data on the effects of HIV and medicines on metabolic syndrome, in fact, are quite inconclusive. These are summaries of recent data with contemporary medicines. And again, I think this is the code for, the code for thinking about this, right? Does it increase the risk? Is it neutral? And as across these studies, it's a mixed story. Some studies will show increased risk, others don't. More specifically on lipids, we know that HIV untreated contributes to dyslipidemia. It actually causes low triglyceride levels and low HDL levels. It's important to recognize that HIV itself affects lipids and affects, therefore, the risk calculators for cardiovascular metabolic endpoints. And so it's important to recognize, therefore, that the conventional risk calculators actually tend to underestimate risk for people living with HIV. Okay, whether one uses Framingham, the ASCVD risk score, the DAD scores, again, tend to underestimate risk. That's an important clinical takeaway. So it's a minimum estimate of risk. Now, I'm going to show you some data briefly from recent clinical trials, or relatively recent clinical trials with modern HIV medicines. These are the Gemini studies that compare dolutegravir lamivudine, that's our drug Dovato, to dolutegravir TDF FTC, and overall in these studies, lipids favor the use of DTG TDF FTC, and that's because of a fairly well-known effect of TDF in lowering lipid levels. But the effect sizes actually are pretty small, and that's the other kind of important takeaway. So medicines have gotten good enough that the differences between one regimen and another are relatively small. In the single study, this was actually an early study that looked at dolutegravir, abacavir, lamivudine. That's our co-formulated drug now called Triumeq versus efavirenz, TDF, FTC, the old drug called Atripla. And here, again, in the bold, the mean changes were small and modest. So again, HIV medicines have gotten pretty good, with the exception, I think it's on the next slide. It's not on the next slide, but I'll get to it. Boosted drugs tend to have higher or greater impact, negative impact on lipids. Okay. Here's studies that look at comparing different modern 3-drug regimens, bictegravir, FTC, TAF. That's Biktarvy versus Triumeq versus dolutegravir, FTC, TAF. And again, overall fasting lipid concentrations are very similar across these modern regimens. Okay. Here's where we see the differences, is comparing dolutegravir as a core agent to boosted darunavir. And again, we've known for, my God, almost 20 years that boosted protease inhibitors are associated with increased lipid levels, including darunavir, which is the, one could argue, the most modern, most widely used protease inhibitor worldwide now. Okay. So, quick summary on lipids. HIV affects lipids, some ART affects lipids, but with most modern regimens, the effect size is relatively modest. And it's important to therefore place all of this into context as we think about the other things that can affect lipids in our patients. And of course, we still need to monitor them for this, because metabolic syndrome, cardiovascular disease is a significant comorbidity in people living with HIV. Let's talk about hypertension. Again, hypertension is a significant risk factor for cardiovascular disease and metabolic consequences for people living with HIV worldwide. And in several studies, the proportion of people living with HIV who have hypertension is scary high, right? So 1/3 to 1/2 of people living with HIV. So this is probably one of the most prevalent risk factors for metabolic syndrome in our patient populations. And of course, there are definitions for what comprises high blood pressure that we should all be aware of. They differ somewhat from country to country, interestingly. And of course, there are guidelines on what the preferred treatments for these things, what the preferred interventions are. And the important feature here is that whether you're a primary care doctor or an HIV specialist, it's important to recognize that people who have hypertension should be treated by somebody. And often one of the big gaps in service delivery is that this is delayed or forgotten because someone else is responsible for it. And so we just say, well, Dr. Marco is going to take care of the hypertension. I don't have to worry about that. Dr. Marco thinks that Dr. Ben's going to take care of the hypertension. And then in the end, it doesn't happen. Okay. All right. So here's the story about modern integrase inhibitor therapies and increased blood pressure. The answer is, well, there's data that says there's maybe a problem, and there's data that says there's not. So the data is heterogeneous, as I said before, and somewhat conflicting. The clinical trials data show no association in well-controlled, well-monitored, regularly monitored people in clinical trials. There was a recent cohort study called Reprieve that suggested that there was an increase. So as we often say, watch this space, pay attention, but right now the data is not, to me, reproducible and similar in directionality. Okay. Insulin resistance, right? So this is the precursor to the overt clinical disease, diabetes. Insulin resistance is the consequence of reduced susceptibility to insulin in peripheral tissues, usually muscle and fat. And risk factors for this include being overweight, being older, certain ethnic groups, especially Black or African American people, and Hispanic or Latinx individuals seem to be at higher risk. Certain medications, including steroids, some antipsychotics, and again, boosted medicines tend to contribute to this. In terms of modern regimens, and I'll show you DTG data here, but I think this is, again, broadly applicable to the modern integrase inhibitors. There's really not much change in insulin sensitivity or insulin resistance in these well-controlled clinical trials. Again, there's heterogeneity because, again, this depends on other factors, as I just said, right? So depending on the population of patients in the study, you may see a signal in one study and not in another, but you have to look at the totality of these data, in this case, many thousands of individuals in these studies. So very briefly, this is the takeaway, right? Insulin resistance and modern integrase inhibitors, save for boosted agents, does not seem to have a relationship to insulin resistance. So that's good news. Doesn't mean that insulin resistance isn't a problem for our patients. It just means from an HIV perspective, this is probably not one of the big worry points. But how about if we go further to diabetes and prediabetes? Again, there's some signal that this may be more common than in people with HIV on treatment than in the general population. So again, this is something that we need to be very mindful of as we go forward, and that people with HIV should be screened, at least in some recommendations, for their fasting glucose levels. Here's the recent data from recent data in general, looking at the effects of integrase inhibitors and plus or minus TAF on prediabetes and diabetes. Again, the arrows kind of show you the direction of the effect, and it's not conclusive. That is to say, again, to me, my interpretation when I see all this is that, again, somebody will come to you and tell you, see, here's this one recent study and it shows the following direction. The problem with that is that if you only look at the one study, you tend not to understand the complexity or observe the complexity of the data. But again, overall, the data is inconclusive, but of course, the subject for intense interest when we think about managing people, not specific medications. Cardiometabolic risk. So this is sort of bringing it all together to the endpoint that we really worry about, or at least one of the endpoints we really worry about, which is cardiovascular disease. And again, here you see the directionality is also inconclusive. Some studies show that there might be increased risk, and other studies show neutral effects. If you look at them in totality, they're more red arrows than equal, but in fact, again, it depends on the effect size and the study size and such, and who did this, how often are the studies conducted. So the number of studies probably is only a soft indicator of the direction, but nonetheless, the conclusion from a number of meta-analyses, including one that we have worked on, will be presenting at the European Conference on HIV and Hepatitis next month, actually just reiterates this, that the data is inconclusive in terms of the specific medication effects. Okay. One study that definitely got some attention recently was this one from the Swiss cohort. This was presented at CROI this year, and basically shows that that integrase inhibitors, this large study of, again, thousands of individuals followed for many years, and shows that the risk difference between integrase inhibitors and other medications was relatively small. And they concluded that there was no increased cardiovascular risk with integrase. Look at my not so convenient watch. Dr. Alexandra, I'm going to allow us to finish on time and allow time for questions, okay? So I showed you a bouillabaisse, a mole of data, okay? A lot of data, much of which in the end says lots of stuff's inconclusive. And as someone who spent a lot of time working on observational cohorts where we see one cohort showing this, another cohort showing something different, that to me is what we call, the statisticians will call, or the policymakers will call, data heterogeneity. When you see data heterogeneity, it doesn't mean that the observation in one study may be incorrect or false, or that the investigators are lying, as is a popular idea in the United States. If the science changes opinion, that means that Tony Fauci was a liar. That's not the case. It means that science makes an observation and tries to fit this into a mixture of effects, right? And a mixture of conclusions. So, but in general, my interpretation of that is that this means that the experiments try to look at the effect of one variable, maybe 2 or 3 variables. And if there's differences when you look at this, it means that there are probably other variables that affect the primary outcome. That's when we say data is inconclusive. It means that there are other factors, those factors that we started the conversation talking about, right? So behavioral, environmental factors, the ability to exercise, food insecurity, housing insecurity, stigma, discrimination, all of those factors, when you take them in their totality, may have an effect size that is the thing that actually causes the arrow to go up or down or neutral. And therefore, my conclusion from this is that the effect size from the antiretrovirals is relatively small, or certainly is not the single dominant factor that controls the outcome. Does that make sense? It's a way of sort of taking all of that heterogeneity and all those data that seem to be going in all different directions and says, it doesn't say that the endpoint of the disease isn't relevant. It just says that the process is complicated and multivariable. Okay. So what do you do with all of that? I just said, well, like all of it is like, this is nuts. I don't know what to do with this. This is complicated data and nobody can agree on anything. Well, we do agree on a number of things, okay? And the data, just to reiterate here without the slide, right? We have shown that these are problems in our patient populations. We have shown that there does seem to be a weight direction increase with 2nd-generation integrase inhibitors and with tenofovir alafenamide, and that seems to be reproducible. I think we all agree that people assigned female sex at birth are at greater risk for weight increase than those assigned male at birth, and that some race and ethnicity groups, specifically in this country, Hispanic and Latinx individuals are at greater risk, okay? So that seems to be directionally agreed upon in all of these studies. However, the rest of it seems to be a bit more inconclusive. So taking all of this, what do we do with it? One, I think this is a really lovely slide because it actually says that the perception of weight gain is not one that is ascertained or preordained by a doctor, a Chinese American doctor trying to ascertain the perception of weight gain for a woman in Botswana is crazy, right? So different cultures, different people have different perceptions of the effect size, if you will, on weight. And that's important when we try to bring this information of disease risk to individual patients. In other words, you have to understand where people are coming from and what their individual concerns are before we really deliver messages about how to improve health. It is important to recognize that people in the general population, and here people with HIV who have higher body mass index, have poor health and poor health-related quality of life than people who are not overweight. Okay, so this stuff does matter because in the end, you can do viral suppression and improve CD4 count, but if you don't improve overall physical health, you don't improve quality of life, we've only done part of the job and not all of it. So to wrap up, treatment guidelines around the world do recommend thinking about metabolic health. The specifics differ from guideline to guideline and country to country. And again, this is an older slide, but the takeaway is the same. I think, again, there are guidelines both for high income and low income countries, and you can interpolate those. And the way I approach this in my country, so I have a US passport somewhere in my backpack. I tend to follow the US treatment guidelines, but I'm very observant of the guidelines in other countries because there are different factors that weigh into how other people interpret the data and what they recommend about implementing that data. Okay. The two sort of guardrails on this, I generally think, are for high income countries, the DHSS or the EACS guidelines for the US or Western Europe, and the WHO for low income countries. And of course, there are the Mexican guidelines as well. And the Mexican guidelines tend to be very similar to, but definitely not identical to, the DHSS. So let me just kind of walk through this bit by bit, because this is sort of this is your clinical takeaway. Okay, so overall, we don't understand that slope or trajectory difference between positive people and the general population, but weight gain is definitely an observation. But the studies tend not to be as detailed as we need to be. They're not endocrine studies, they're virology studies from which we try to glean information about endocrinology. So future studies are going to do much more detailed look, not just at weight gain, but where is the weight gain? What is the tissue that is gaining in mass? Is it fat? Is it muscle? Is it water? And so on. In control groups in these studies are quite difficult to get. The reversibility of weight gain is very unclear, and there's a difference in terms of weight gain in people who are therapy naive and people who have been on therapy for a long time with suppressed viremia. And in this area, some of the newer medicines on GLP antagonists actually, in a way, have superseded the discussion. So in endocrinology clinics, people just say, well, we're just going to use a GLP inhibitor and worry, well, we'll keep trying to figure it out. We'll move in this direction, even in advance of the clinical trials in positive people. The clinical trials that do exist are small, but actually suggest that there's the same effect. Lastly, the question about reversibility versus endogenous factors remains unclear, and unclear also about certain genetic factors. Okay. But in the end, optimizing cardiometabolic health, optimizing overall health, physical health, and quality of life is more than just managing weight, right? And so these were recommendations that come from summarized from a variety of guidelines about doing things to reduce risk. Smoking reduction, tobacco reduction, and cessation probably is the single most important thing we can do, and is very understated in most of these conversations. This is the first time out of, I don't know how many, 40 something slides that I've talked about tobacco. Tobacco, 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 right? Improving physical activity can improve cardiometabolic health. Actually improving rest and sleep improves cardiometabolic health, and we don't talk about that very much. Makes me wonder about the health of all of us physicians, because we tend not to sleep as much, we tend to work too much, and we tend to just say, well, if you're a good doctor, you'll just work when you're tired, right? Interestingly, reducing sitting actually seems to also help, and of course, improving diet. So I've taken nearly the time, Dr. Alexandra, that was allotted to me, but I also wanted to allot time for questions, sus preguntas, and a discussion. For my first opportunity today, muchísimas gracias for the invitation to return to GEVIHS, to return to Mexico. Thank you very much. This is my email at the bottom. It's benjamin.x.young@beefhealthcare. Okay. So thank you.
Thank you very much, Dr. John. Hacemos entrega de su constancia y un reconocimiento por
Un
parte
regalo.
de GEVIHS.
Gracias.
Muchas gracias.
¿Hay preguntas o discusión?
¿Alguna pregunta?
Doctora.
Hola, buen día. Acerca de la plática que nos dio ahorita sobre el manejo de hipertensión y diabetes, dislipidemia en pacientes que tienen VIH y, por ejemplo, que son adultos de 40, 50 años, es relativamente fácil atenderlos porque el paciente está consciente que va a tomar pastillas, ¿no? Pero estoy atendiendo más en la consulta a pacientes jóvenes de 20 años, un poco más, un poco menos de 20. Y yo los clasifico como los que hacen mucho ejercicio, van al gimnasio, toman suplementos, y los pacientes jóvenes que no hacen nada y que solamente suben de peso. Y ese es el grupo que para mí es más difícil de atender. Entonces, y no quieren tomar pastillas, ese es el punto. O sea, uno sabe lo que tienen que tomar, pero el paciente no quiere tomárselo. Entonces, ¿cuál sería su recomendación para el manejo de esos pacientes jóvenes con riesgo de síndrome metabólico?
Sí. No, so thank you for your question. And believe it or not, I think I understood See, without translation, okay? I'm going to put this down so I don't drop this. So you raise a really important question about, well, first, your question was more specific to younger individuals, but I think it's actually a general observation as well. First, which is that people don't like taking medicines, and they especially don't like taking lots of pills. And I think this is a generality, which is why we have fixed dose combinations, which is why our company has advanced long-acting medicines, because it's just fewer pills, fewer times to take medicines. It's complicated, especially with complicated lifestyle. It's interesting. The only good thing about getting older or taking care of older people is that older people tend to be more adherent to medicines, right? But for younger people, again, the pill counts, dosing complexity is a really significant barrier to successfully administering medicines that otherwise would be beneficial. And we have to acknowledge that. So the subject of adherence is particularly problematic. And this is where I have two comments to this, really, in terms of what to do about this. Number one is to acknowledge that it's difficult. And as I often will say to my patients, perfection is not required. Because we tend to take this approach, especially from the HIV perspective. You must be adherent to your medicines 100%. And we take a very paternalistic, if not church kind of approach to this. It's religion. And if you don't take it 100.0%, you have sinned, right? And you will go to hell and die if you miss one dose, okay? That cannot be the message we deliver, but we often do. Even if we don't say it as I just did, we imply that you are a failure as a patient if you are not 100% or 95% or even 90% adherent. And rather, especially for medicines where it is less critical for adherence, to make sure that that's not the message. Adherence is important, but perfection is not, okay? That is a subject in the broad context around the science of adherence, but it also is a subject in the humanism of medicine. We have to understand and appreciate the humanity of the person in front of us and acknowledge that to them, because without that, then we are just another priest with a religion of 100% adherence, right? So that's really, really important. The other is in acknowledging this, let's say hypertension, let's say it's lipids, for example, where again, if you miss a dose, it's not going to be a death consequence, okay? It's just to acknowledge that, and especially in these two areas, to acknowledge that there are behavioral modifications, physical activity and exercise, smoking, another one that's also religious. You must quit smoking or you have sinned and will die. Right? So there's a pathway to reduce smoking rates, and so the humanistic part of it acknowledges it's difficult to quit a medicine or a drug that is addictive, but let's try to reduce the risk, right? Instead of smoking 20 cigarettes a day, maybe this week we will agree that you will smoke 19 or 18, right? And a stepwise reduction in this. Really constructive discussions around these other modifiable risk factors, again, physical activity and diet, but one that is not absolute, but is humanistic, right? So how many steps, many of us have iPhones, right? So how many steps does your iPhone say that you've done? Can we do 5% more next month? Not 200%, just 5%. And get people in this idea that rather than failing and being failures or sinners, that they've actually had incremental improvement and success. And that recalibration of the message, in my personal experience, has been very effective in getting not everybody to be successful, but many people to have less risk. And ultimately, that's, I think, our job. And in the process, we become a bit more humanistic in understanding who our patients are, and curiously, they become more understanding about the humanistic aspects of the doctors that are taking care of them. Okay. Thank you.
¿Alguna pregunta más?
Entonces,
Dr. John.
muchísimas gracias.
Vamos a esperar unos minutos que lleguen todas las autoridades para hacer el protocolo de integración.